October is Breast Cancer Awareness Month, and today we are meeting with Dr. Max Polo. Dr. Polo, thank you for finding the time for the interview.
Sure, thank you for having me.
In 2011, more than 200,000 women will be diagnosed with breast cancer, and one of them will lose one breast, and even in early stages of diagnosis, most of them will lose both breasts. And these women will face a very severe decision how to find the right oncologist and how to find the plastic surgeon. Dr. Max Polo is a diplomat of American Board of Plastic Surgery, and he has been in private practice for more than 12 years. And he acquired the highest degree of expertise in breast cancer-related subjects. Dr. Polo, can you please define the differences between cosmetic and reconstructive procedures?
Well, there are probably more similarities than there are differences. As far as breast surgery is concerned, it's almost like there's a spectrum of defects that we're reconstructing. So cosmetic surgery, they're more minor cosmetic abnormalities or defects. The breasts are smaller than the patient would desire. The breasts are larger than the patient would desire. Maybe there's some slight asymmetry between the two breasts. We're always concerned with symmetry in breast surgery. So with the reconstructive surgery, some of the differences are who's paying for the procedures. Cosmetic surgery is usually paid for by the patient and not covered by insurance. Most reconstructive procedures are, as far as breast cancer reconstruction, are covered by insurance. And then there's some gray area in between. So, as far as the technical aspects, they're very similar. The procedures that we do, the different steps of the procedures, the technology involved in the science, there's a great deal of overlap there. So really I think the biggest difference is the degree of abnormality or deformity that we're trying to correct or reconstruct.
Thank you. Dr. Polo, you participate often as a volunteer and as a speaker in the community, lecturing about cancer-related questions. What, in your opinion, are the most common factors that are causing breast cancer, and what are the major ways to prevent it?
Well, we know about some of the contributing factors, so therefore we're able to prevent some of them or help prevent some of them. There are genetic factors that contribute to the development of the disease. We've identified a few genes that we know add to the risk. We can test for those genes. There are other environmental factors, primarily women's exposure to estrogen over a lifetime. So anything that contributes to higher exposure to estrogen, early age of menarche, or the beginning of menstruation, delay in having children, or a patient being nulliparous and not having children, no pregnancies, and other exogenous forms of hormone exposure, birth control pills or other types of hormone medication. And then there are environmental factors such as diet and possible exposure to other carcinogens.
Do you think the fertility treatment can contribute in certain ways to the risks of developing breast cancer?
Well, certainly if there's some estrogen treatment or increased estrogen exposure involved with the fertility treatment, which there very well may be, depending on what the problem with fertility is.
Breast cancer diagnosis is usually a very devastating state for any woman that is going through this type of treatment. And usually for women it's very difficult to cope emotionally with this diagnosis. Dr. Polo, based on your experience, how women go through the treatment and how do they find the support in order to go through the treatment? Dr. Polo, you participate often as a volunteer and as a speaker in the community, lecturing about cancer-related questions. What, in your opinion, are the most common factors that are causing breast cancer, and what are the major ways to prevent it?
Well, we know about some of the contributing factors, so therefore we're able to prevent some of them or help prevent some of them. There are genetic factors that contribute to the development of the disease. We've identified a few genes that we know add to the risk. We can test for those genes. There are other environmental factors, primarily women's exposure to estrogen over a lifetime. So anything that contributes to higher exposure to estrogen, early age of menarche, or the beginning of menstruation, delay in having children, or a patient being nulliparous and not having children, no pregnancies, and other exogenous forms of hormone exposure, birth control pills or other types of hormone medication. And then there are environmental factors such as diet and possible exposure to other carcinogens.
Do you think the fertility treatment can contribute in certain ways to the risks of developing breast cancer?
Well, certainly if there's some estrogen treatment or increased estrogen exposure involved with the fertility treatment, which there very well may be, depending on what the problem with fertility is.
Okay. Breast cancer diagnosis is very devastating to any patient. And with the advances in modern plastic surgery, women can find the new lease and gaining their confidence again. Dr. Polo, based on your experience, how women usually cope emotionally with this diagnosis?
Well, it's definitely a life-changing event. The diagnosis itself and then the subsequent treatment, which is often very complex. So I think there's always sort of an initial shock, and there's so much to deal with at the time of the initial diagnosis as far as the workup and all of the decisions regarding what treatment each individual patient selects, both for the cancer treatment and then the reconstruction treatment if that's something that is opted for at the time of the initial diagnosis. So it is difficult. I mean, there's an adjustment required, and there are lots of issues to deal with as far as the treatment, which can go on for years often.
Dr. Polo, it usually takes a group of specialists to define the treatment plan for breast cancer at any stage, and the treatment is usually very complex. How do you cooperate with your colleagues like medical oncologists and breast oncologists?
Right. Well, I mean, definitely for the most effective treatment, it requires a multidisciplinary team approach and lots of cooperation between the different specialists involved. So usually the diagnosis is made by, possibly a primary care physician, family practice physician, a gynecologist, and the patient is then referred to the oncology specialists, most often the surgical oncologist, because their intervention is required to complete the diagnosis. And if cancer diagnosis or diagnosis of premalignant disease is made and further surgical treatment is indicated, then that's usually when the reconstructive surgeon becomes involved. But there's lots of overlap of care, and there is coordination required as far as the steps along the way. One treatment by one specialist affects the timing and the options of treatment by another specialist. So there is close cooperation between the oncologist, both the surgical and medical oncologist, and the reconstructive surgeon throughout the process.
Thank you. Dr. Polo, can you please tell more about different types of breast cancer reconstructions and why women prefer immediate versus delayed breast cancer reconstruction procedures?
Well, I think most women initially, when they have the diagnosis, they're aware of the options for immediate reconstruction. Most are interested in some type of reconstruction. So they at least explore that option, the time of the initial diagnosis. I think we talked earlier about the, emotional response, especially early on when you're first diagnosed, and then which can be overwhelming. And I think there's so much to consider as far as, having the diagnosis of cancer, what the options are for the treatment of the cancer, that many women are looking at the reconstruction as sort of a silver lining, but don't have the time initially to invest in exploring what is involved, and I think many don't realize that this is another complex part of the treatment, and that there are lots of decisions that need to be made, and not always is immediate reconstruction the best option. But we're often seeing patients early after the diagnosis, and we're considering immediate reconstruction. The benefits are that it saves time. I guess what's most appealing about it is that you don't have to wake up after surgery and have lost the breast. There's at least the beginning of a reconstruction that has been completed early on. So I suppose that's what's most appealing about immediate reconstruction. There are benefits technically, from the reconstructive surgeon standpoint, and having the opportunity to at least begin the reconstruction at the time of the mastectomy. If we can preserve more tissue, more skin of the breast, we can at times have the opportunity to achieve, the ideal reconstruction. Sometimes when we're doing a delayed reconstruction, not always, but sometimes, we've lost a little bit of our advantage to have the absolute best possible outcome.
Dr. Polo, more and more young women under the age of 35 are affected with breast cancer. So what would be your recommendations regarding the self-exam and the time of early mammograms?
Well, the disease is becoming more and more prevalent, and we are seeing women in their 30s or even 20s. Sometimes, as a reconstructive surgeon, my exposure is a little bit skewed because we're seeing more of the younger patients probably for reconstruction. But I don't think it's never too early to start self-examination. There's no risk in that. There's no radiation exposure. So certainly, any woman, in their 20s should be doing regular self-examinations. Not only does it, allow you the opportunity to detect disease if you're one of the unfortunate ones diagnosed that early, but it allows you to get to know your body so that, later on when the risk may be more, you're aware of, what you're feeling when you examine yourself and what's normal for you and what is abnormal for you. But you need to educate yourself as far as your family history and what your risk factors are. Be aware of what other risk factors are and what your exposure to those are, so that you know when you should be performing other diagnostic tests for screening, for example, in addition to self-examination.
So what would be your recommendation regarding the time of the first mammogram, especially in the light that the time of the first mammogram and insurance coverage now is getting postponed even after 40 to the age of 45?
Right. The issue with insurance coverage is what it is. I think most medical professionals agree that 40 is the age where most women should begin having mammograms. The frequency of that may be arguable. Not everyone feels that an annual mammogram for women over 40 is necessary. Some feel that semi-annual is adequate, especially if there aren't additional risk factors. Many physicians and breast cancer experts feel that women who have additional risk factors, especially identified genetic risk factors, should begin at 35 or even 30 perhaps.
Thank you. First of all, what are the different options for breast reconstruction?
Well, the different options in general are in reconstruction with implants and reconstruction using a patient's own tissue. So, which is the best option for each individual patient depends on what type of treatment they're having for the cancer, depends on their personal preferences, depends on their medical history and surgical history. So we take all of these things into account.